Thank you all for coming to this session, also online. I'm very much inspired by all the talks I already have heard, and I'm super happy to can contribute to this conference. As Eva already said, spiritual care is not so much integrated in mental health care. And the spiritual caregivers like us, we mostly come on the clinics. And today, more and more often, people get their treatment at home in ambulatory mental health care. And the spiritual caregiver don't have the same financial resources to give spiritual care to these patients. And that's why it is important to think about how spiritual caregivers like us, the chaplains, can support the ambulatory mental health care professionals to give spiritual care in at least in a basically sense. So my presentation will be about the views of these professionals on spiritual care in their treatment. It is an empirical study, and one of my respondents say spiritual care, that is that you talk about very essential things. And I thought like, well, that's a beautiful title for my presentation. First, the research focused. I focused on what are the motivation of these professionals, the professionals in ambulatory mental health care, to give or not to give spiritual care. How do they think about it? What motivates them? And how does this relate to their competence in spiritual care? And how does it relate to their personal spirituality? Maybe one of you also was on the lecture from yesterday, where Christopher Gerrit Glas said that your personal spirituality is not out or away when you give healthcare. Your personal background, you bring it to your work. You cannot do it if it is not there. So that's why I use this triangle as a basis and the focus of my research. Therefore, I used a bunch of theoretical background. I only give here one highlight, and that is about different approaches on spiritual care, which are observed among these professionals by different researchers. And the two different approaches are about how do you understand the word spirituality or zingeving in the Dutch language, and what is your attitude in spiritual care. The first approach understands spirituality as meaning in everyday life. In Dutch, we would say alledaagse zingeving. And meaning in everyday life is like you have meaningful activities, you have a purpose. For example, what is a reason to come out of your bed? And professionals who understand spirituality in this way tend to have a pragmatic attitude. And a pragmatic attitude in spiritual care is a focus on well-being, on empowerment, practical guidance, and giving information. Well, that is one approach on spiritual care. The other approach on spiritual care is slightly different and maybe more close to how chaplains are educated. Professionals in this approach understand spirituality more as existential life questions. In Dutch, we would say existentiële zingeving. And this is also affecting the attitudes. If you understand spirituality as existential life questions, you have a more contemplative attitude on spiritual care, which means that you focus on being present, you slow down, focus on introspection and symbolic languages. So with this theory in mind, I set up my method. This study is a phenomenological, qualitative, interpretative research among professionals working in ambulatory mental health care with people with severe mental illness. And I did 3 types of data collection around a basic training in spiritual care. I will show you my 6 main results. They are composed around this triangle. We start with motivation and how does it relate to competence and personal spirituality. my first main conclusion is that professionals are motivated for spiritual care. They really see it as an important part of their job, especially because these professionals work with people with a severe mental illness who tend to be very long in treatment, and they see it as a part of recovery to give spiritual care. One of the respondents put it like this: yes, I also hand out pills and stuff like that, but it is all about helping people to have a meaningful life here. So they find it important and they are interested in zingeving, in spirituality. But at the same time, they give some reasons why they choose not to give spiritual care. Some of them that the patient is in crisis, or there is no trust relation, or the organization don't give me enough time to be slowed down and to have time for introspection. But the most important in respect to my research focus is that they also not always feel competent to give spiritual care, especially when it comes to religious or existential topics. Another important reason to choose not giving spiritual care has to do with the professional's personal spirituality. Because when there is a big difference between the background of the professionals and the spiritual background of the patients, sometimes this can be a reason not to attend a topic. One respondent said it like this: if someone is really deeply religious, well, I am not religious, and I also can sometimes get annoyed by some beliefs from a faith. I can say, for example, I'm not that religious myself, so I don't know that very well. But that's the ending point. So the personal spirituality of the professional can be, in some cases, a reason not to give spiritual care. And this is especially the case with religious topics. And in these cases, the professionals would like to refer to a chaplain. We go further in detail of the research, of the results of the personal spirituality and how does it relate to motivation and competence. And then we come back to the theoretical part about the approaches. So the way spirituality is understood depends highly on the professional's personal spirituality. And in this, it is not so much important what is their religious affiliation, or if they are religious or not religious, or what is their spiritual identity. That's not so much important. The most significant was the affinity. The affinity to consciously deepen your own personal spirituality, to read about it, to reflect on this often, to speak about this with friends oftenly. So it is more about the affinity than the religious identity, which make a difference. And so we see that professionals who don't have this affinity so strongly, they tend to give emphasis on meaning in life. So they understand spirituality as having a purpose, or that you have meaningful activities. And professionals with this affinity, so who feel very strongly that spirituality is an important part in their life, they tend to emphasize on existential life questions. And this difference between professionals with and without affinity is also found in their attitude in spiritual care. So the professionals without a strong affinity has mostly a pragmatic attitude on spiritual care, and the professionals with affinity show mostly a complementative attitude on spiritual care. So it really makes a difference how your own personal relation to the topic is. And the thing is that the first approach is way more seen than the second. So the second professionals are in minority. And this also has an impact on competences, because the competence of being aware of your own spirituality is seen in the literature, and maybe you already have heard it in talks before today and yesterday, is seen as one of most important competence in giving spiritual care. And from the interviews and the observations I did, it became clear that most professionals are not so much used to do that, to reflect on it. It is this minority part who has this affinity to do that. But the interesting thing is that at the same time, they do show some competence in being aware not to put your own personal spirituality on the patients. All the professionals I spoke to find that very important. So on that part, they are like super alert or super aware. The respondents find it important that their work conditions give more space to reflect on their patient's spirituality, but also on their own spirituality. So they have some motivation to improve the competence in spiritual care. They would like to be able to refer to a chaplain, but also would like to have support from a chaplain to improve these competences in spiritual care. There is another quote yet. One of the respondents say about the team of spiritual caregivers, which are mainly Eva and me and 4 other colleagues. It is regrettable that a team of spiritual caregivers is so small. I would like to exchange thoughts more often. And especially in the ambulatory mental health care, this is way more rare than it is in the clinical setting. So these were the main results from my research, and I will put them in light to the theoretical background a bit. Tell me if I'm talking too long. Okay, so still have time for this. We're starting with motivation. The results confirm the literature that there is a relation between how much you feel competent in giving spiritual care and you actually give it. So the research of Vogel and Schep-Apperman shows that although people are motivated, they still tend not to give so much spiritual care if they feel like I'm not competent in addressing existential life questions, for example. And also my results confirm the research of Neil Ameron and Meuse, that when there is a gap between the spiritual background of the professional and the spiritual background of the patients, the professionals tend to avoid the topic. And especially in the Netherlands, where the professionals in mental health care are way less religious orientated than their patients, this is a good thing to know and to keep in mind. Then we move on to the personal spirituality. We saw in my results that the way the spiritual care is approached by the professionals is pretty diverse. The majority of professionals focus mainly on meaning in daily life and don't address life questions that often. And Cavendish and colleagues state that it is important to have a common sense about what is spirituality and also have a broad sense about what is spirituality. So not only meaning in daily life, but also the existential life questions, because otherwise, if you approach this too narrowly, there is a lot of spiritual needs from the patients who are not attended to. We also saw that the professionals' approach on spiritual care is highly dependent on their own spirituality. And Gerrit Glas, which we saw also yesterday, state that to give or not to give spiritual care should not be something about some personal interest, but should be a professional thing. So it should be structurally addressed. Also, if you do not really have this affinity, of course, it can be good if you really feel some resistance to refer to another colleague or a chaplain, but it should not be dependent on personal interest if the patient is able to speak about these topics, yes or no. Yeah, I'm going to the conclusions. I think I will skip this because the conclusions and the recommendations are maybe more important. Well, concluding. Although professionals see spiritual care as an important part of their job, they tend to not give this always, for professional as well as personal reasons. And since spiritual care is not structurally integrated, it is highly dependent on the person's affinity, how spiritual care is given and approached. And especially the existential life questions are getting in danger for this. So our recommendations should be that there is a structural and integrated spirituality, and not only the pragmatic, but also the complementative approach in spiritual care. Therefore, it is needed that the professionals get some training about reflection on personal spirituality, in signalizing existential life questions, and in complementative attitudes, since this is not always the case in the normal training professionals get. And then also a recommendation I want to conclude with is that it can be helpful when there are organizational structures in which professionals who don't have that affinity so much are supported by their colleagues or by chaplains who have this affinity, to prevent that spiritual care is only approached very narrow and the existential life questions are not addressed. So far, my conclusions and recommendations. The next presentation will go on my story. It is like a kind of following up. Thank you for listening.